as the Nigeria Center for Disease Control, NCDC, reports that the country has recorded 13,204 suspected cases. Now, out of the suspected cases, 8,406 were confirmed from 114 local government areas across 19 states, including the Federal Capital Territory. The Director General of the NCDC, Ifedayo Adetifa, who gave the surveillance updates to a diphtheria task force inaugural press briefing, added that the federal government is finalizing plans to establish a national diphtheria laboratory for the testing of suspected cases. A diphtheria, which is caused by a toxin produced by the bacteria Corynebacterium diphtheriae, is a vaccine-preventable disease covered by one of the vaccines provided routinely through Nigeria's childhood immunization. Now, we're joined this morning by the Director General, Nigeria Center for Disease Control and Prevention, Dr. Ifedayo Adetifa. Good morning. Thank you so much for your time, and great to have you on the program.
Thank you for having me. Morning.
Now, I'm going to start with saying how worrisome it is that we're talking about 13,000 cases. About 2 weeks ago, it was I'm not sure how many they were, but definitely not 13,000. Does this maybe shed some light on how fast the cases are growing or expanding in Nigeria?
Thank you very much. Let me just clarify that we are not setting up a new national laboratory for diphtheria. We are working on expanding capacity of state-based public health labs to make diagnosis of diphtheria like we do for other conditions, meningitis and cholera. Yes, we are prioritizing the response to the ongoing diphtheria outbreak because we, after the initial response and the reduction in cases, we are seeing a so-called second wave, which is increasing number of cases and addition of more states that were not previously affected. The spread is not surprising because what it means is that there is a ready-made pool of sufficiently large susceptible populations that transmission can occur in, resulting in the cases that we are currently having to deal with. Back to you.
All right, let's talk about diphtheria and how exactly it shows, how exactly it presents itself, the symptoms, and how people can protect themselves. It seems that we had more awareness when it came to COVID-19 than we did to diphtheria, and with the speed at which it's spreading, we'd like you to help us shed some light on how people can identify and protect themselves from this.
Well, diphtheria is a respiratory illness, so we commonly present early in the disease with a fever, with runny nose, with sore throat, cough, and red eyes. And as it progresses in severity, we can have difficulty in swallowing, difficulty in result of a patch that occurs at the back of the throat, basically. And this patch, because it blocks or provides some form of a blockage, is why there is now difficulty to breathe and to swallow, and a backing cough may then ensue. It's also associated with swelling in the glands in the neck and under the jaw, which may lead people to sort of suddenly have a bull-like appearance. If anybody has symptoms like I've described, including the less common presentation where you can have new onset rash or patches on your skin, then they should present to the nearest health center or diphtheria treatment center to be investigated so as to confirm the presence of diphtheria or not. It's also important that when we see suspicious cases in communities, that the local government or state disease surveillance and notification officers and consequently the state ministries of health are notified. They can also help with sample collection to make a diagnosis, and diagnosis of diphtheria is done at no cost to the patient.
All right. I'd also like to confirm that we would not sort of have a number of the issues that we had at the onset of COVID-19, because there were reports that some people would go to hospitals, and once the doctors or the health professionals saw that they presented signs and symptoms of COVID-19, they will immediately turn them back. So I'd like to confirm that we have adequate information with the health facilities, the hospitals around, and that anyone who has this, I mean, we don't know, we don't know how many diphtheria detection facilities we have around the country. So for those who don't have access to these just yet and have to go to a hospital, we want to confirm that they will not be turned back and that the hospitals are properly informed on the next steps to go, to go through if they find out that this person potentially has diphtheria.
This is not COVID, and I think it's important that we do not, I know we've just come out of the pandemic response. It's important that we do not, draw an unnecessary linkage or comparison to this. The hospitals will not turn back suspected cases of diphtheria because, I mean, they, as I say, they present with symptoms that are common to a lot of respiratory illnesses. The concern in some of the high burden states at the moment is that because this is a re-emerging disease that previously was largely unseen because of the use of an effective vaccine, many healthcare workers have not seen cases of diphtheria before and therefore have something that we call a low index of clinical suspicion. But the interaction, engagement, and education of health promotion, community-based health staff, hospital-based staff, and the like is ongoing to make sure that they are adequately sensitized and suspect or consider diphtheria as a possible diagnosis that needs to be ruled out when they see people with suspected illnesses. Now, in states, there are designated treatment points for diphtheria. So when a diagnosis is made or there's a clinical suspicion, patients may then be sent to those locations to be admitted to receive treatment, because early treatment is very important and is the most predictive factor of a favorable outcome. So it's important that we have early treatment started with antibiotics and even with the diphtheria antitoxin where it is indicated. Back to you.
All right. Now, you spoke earlier about expanding laboratories, not building new laboratories, but expanding on the current infrastructure that we have. Give us a picture of what the current infrastructure size is like, and what it would take. What is required if you want to expand on these laboratories.
Well, there are 14 laboratories in the country that have a capacity to do basic diphtheria testing, and we are currently optimizing 5 additional laboratories to join. Most of these laboratories, thankfully, are in the high burden states. Some are in other parts of the country that are not seeing or are not seeing as many or are not seeing diphtheria at all, because this was part of being prepared in case this happened. Ideally, we shouldn't have a challenge with diagnosis of diphtheria because it really is basic bacteriology, including a specialized test to be sure that we have the type of bacteria that produces the toxin that causes the symptoms associated with diphtheria. And that has been the challenge. So we are, the process of setting up existing labs to make diagnosis includes making an assessment. Sometimes they need specialized equipment like biosafety cabinets, which we have shipped out to as many of the labs that require those. And of course, some training and then provision of the laboratory consumables that are needed to get them to work, and then follow up to ensure that people are actually successfully carrying out the laboratory procedures that are required to make diagnosis. So that takes a bit of work because people have not been doing this and have not been making diphtheria diagnosis. So it's a bit slow, but we are slowly, we keep pushing to get to the point where there are laboratories in all of these states with the highest burden. And of course, we need to also keep an eye on the other states where diphtheria may not be is not being reported at the moment to make sure that they are also ready.
Yeah, but I mean, is this funded by the NCDC, or is it expected to be funded by the states where these laboratories are located? And how do you ensure that proper funding goes into these things?
Well, at the moment, the NCDC, through its own resources provided by government and through the Federal Ministry of Health, and with the support of many partners, for example, the UKHSA that has been helping us with training, and others, the WHO, we are providing, as I said, necessary equipment. We cover the cost of training, and we also are providing support with the consumables that are needed. This, as you know, laboratory consumables, because they are mostly imported, are quite expensive. So this is a challenge in terms of if we have to be doing this for longer than we are doing it already. So that's the challenge there. But government, with also support from various partners, is covering the costs of training, setting up even the specimen collection materials, which is why there is no charge for diphtheria diagnosis.
All right. Thank you for talking to us about diagnosis and the centers around the country. Now let's talk about the treatment. What's the treatment procedure like?
Well, treatment involves giving an antibiotic. The antibiotics that are given either to people with diphtheria or people who have been in contact with diphtheria cases are relatively simple and commonly available. The challenge for patients who are hospitalized is having to take oral antibiotics or the oral formulation of this antibiotic. And to overcome this, we have now procured quantities of intravenous erythromycin specifically to aid treatment for patients who obviously have problems with swallowing or even respiratory difficulties. So that's one mainstay of treatment. The other is to administer Diphtheria Antitoxin, which also for the first time in the history of any outbreaks in the country has also been made available for the use in patients. The challenge with Diphtheria Antitoxin is that it is expensive and there's limited global manufacturing capacity for this. So it is posing a challenge in terms of being able to lay our hands on the quantities that we need or that we desire. But otherwise, we do have Diphtheria Antitoxin in country, and we are looking to receive some more supplies as well.
All right, I think my final question would be in terms of prevention. Thank you for sharing the care, contraction care. But let's talk about the prevention of diphtheria. I did read up somewhere about how some of the vaccines are part of what has been administered to us as children. But I need some clarity as to the vaccines and preventive care against diphtheria.
Well, we have a problem with diphtheria now because over many years, we have slowly and steadily accumulated a pool of people who are susceptible to diphtheria because they were not vaccinated as infants. As you know, the routine childhood immunization schedule and vaccines as provided for by government through the NPHCDA is available to be given to children when they are 6 weeks old, 10 weeks old, and 14 weeks old. This vaccine is called the pentavalent vaccine. It protects against 5 diseases, including diphtheria. Now, if we had a high proportion of children that are born every year receiving that vaccine, we will not be in a situation where we are at the moment. So to turn off the tap, for want of a better description, that is providing or producing these cases, we need to vaccinate the susceptible population that are currently generating or at risk of becoming cases. As you would have heard, most of our cases are in the 5 to 9 and 10 to 14 year age group. So a 5-year, and most of them have not been fully vaccinated or have not even received any vaccine for containing diphtheria, a diphtheria-containing vaccine when they were infants. Now, this problem didn't occur now. If you are 5 years old this year and did not receive a vaccine or have no history of receiving vaccination, it means that the opportunity to vaccinate you was missed 5 years ago in 2018. And if you are 14 by extension, the opportunity to vaccinate you was missed in 2008. So these are historical gaps in vaccination coverage that obviously have not been addressed by the more recent efforts to strengthen routine immunization and to make sure that newborns or infants are vaccinated. That more recent efforts to strengthen delivery of vaccines to newborns has been beneficial because infants are not significantly affected by the ongoing outbreak. We don't have that many cases among infants, but most of the cases are in the older populations, including even in adults.
Right.
There are more cases that are 20 years and above than we have infant cases. So prevention requires good vaccination coverage. The target really should be that if you have a cohort of children born every year, you want to vaccinate 80 to 80% of them with a diphtheria-containing vaccine to make sure that they are protected and there's enough herd immunity to even protect the rest of the population.
And we certainly hope that, this is something that would be rolled out as soon as possible in the nearest future, so we don't have to revisit this conversation again. Dr. Ifedayo Adetifa, thank you so much for joining us this morning on Breakfast Central.
Thank you for having me.